When we think about addiction counseling, group therapy is not just an add on service, it's often the backbone of treatment. Irvin Yalom described groups as a social microcosm, a place where dynamics of daily life, conflict, connection, trust, avoidance, intimacy, and play out in real time. What happens in a group is rarely just in group. It's a living snapshot of how clients relate to themselves, to others, and to larger systems around them. So when we ask the question, why groups? In addiction counseling, it's important to move past the superficial answers. Yes, groups are efficient, and yes, they allow us to serve multiple people at once. But the real reason group therapy has become the backbone of substance use treatment is because addiction is not just an individual disorder. It is, at its core, a disorder of disconnection. For people in recovery, that mirror of the group is powerful. They don't just talk about change in the abstract, they practice new ways of relating right there in the room, testing out honesty, accountability, and vulnerability, with feedback and support from others walking the same path. Recovery is about connection. Harm reduction approaches are grounded in the reality that people heal in community, not in isolation. A person who's been stigmatized, criminalized, or marginalized can find something radically different in a group that values their voice and honors their goals. Whether that goal is abstinence, moderation, or simply reducing harm, groups create space for those goals to be spoken aloud and held with respect. This brings us to another why. Why are there different levels of care? Partial hospitalization, intensive outpatient, and outpatient, each with their own approach to group work. Again, it's not about filling chairs or billing insurance. It's about matching the intensity of treatment to the acuity of the need. In PHP or partial hospitalization, groups meet daily for several hours. These clients are often newly sober or in withdrawal stabilization or facing crises that demand a highly structured, almost full-time therapeutic environment. The group becomes a holding environment, a safe container to stabilize and prevent immediate relapse. In IOP, clients attend 9 to 15 hours of groups per week. They're stable enough not to need 24-hour monitoring, but still require frequent structured support. Here, groups act as a bridge, teaching coping skills, addressing ambivalence, and supporting clients through transitions like reentering the workforce or reuniting with family. In OP, clients may come in once or twice a week. At this stage, group therapy shifts towards relapse prevention, sustaining progress, and helping people integrate recovery into their identities, relationships, and daily lives. Each level of care reflects an understanding of readiness, relapse potential, and recovery environment. It recognizes that a person 1 week sober, unhoused, and in acute withdrawal has a different group need than somebody with 2 years in recovery navigating workplace stress. Motivational interviewing reminds us that ambivalence, resistance, and relapse are not failures. They are parts of the change process. Groups allow us to hold that reality collectively. They give clients a chance to see themselves in others, to borrow hope when their own feels thin, and to experience accountability without shame. So the why comes down to this. Groups are central because they meet people where they are. They provide belonging, accountability, and the chance to practice recovery in real time. And they scale across levels of care not because of insurance demands, but because human beings need different levels of structure and support as they move through the stages of change. Before we dive in, let's just take a moment to look at where we're headed today. Group therapy and addiction counseling is rich, layered, and sometimes messy. My goal is to give you both the frameworks and real-world tools to help you navigate that messiness. So here's our roadmap. We'll start by looking at different group modalities and structures, what kinds of groups exist, how open or closed groups function, and the role of mutual aid groups like AA or Smart Recovery. Next, we'll walk through the stages of group development, from forming to storming to adjourning. We'll talk about how these stages show up in addiction treatment, especially around ambivalence and conflict. From there, we'll discuss how we actually measure success in groups, not just attendance, but engagement, connection, and movement through the stages of change. We'll also explore therapeutic factors unique to groups using Yalom's 11 factors and consider how they show up specifically in substance use recovery. Then we'll shift to the counselor's role, how to set norms, manage storming, balance empathy with authority, and create trauma-informed inclusive cultures. We'll also spend time on realities, ASAM criteria, harm reduction, mixed motivation groups, and the extreme parameters where discharge or referral may be necessary. Finally, we'll close with some of the specific issues unique to addiction groups: trust, relapse disclosures, diversity of histories, and end with what it means to care for yourself as a group leader. So that's our agenda. Think of this lecture as a toolkit. You'll leave with ideas, examples, and language that you can use in your own group work. So first, touching on group modalities and structures, we're going to talk about types of groups. When we design groups in addiction work, we're not just picking a topic. We're choosing a way for people to practice safer connection. You'll see 4 broad aims show up across programs. There's educational or psychoeducational, where we're going to build knowledge and skills. This is where we might talk in depth about triggers, cravings, refusal skills, and assertive communication. These are structured, goal oriented, and easy to adapt across levels of care. If you skim a group manual, you'll notice session plans for high risk situations, managing urges, assertive communication, effective refusals, and termination. These are classic psychoeducational building blocks for SUD groups. There's also the vocational type of group where you might talk about job search skills, scheduling, managing workplace triggers, practical stability work that supports recovery capital. There's also social groups where you might do some pro social practice, giving and receiving feedback, peer support, conflict, and repair. And then there's personal and process groups, exploring family roles, thought patterns, trauma responses, attachment needs, and identity and recovery. These groups slow down and work with what's alive in the room to help members experiment with new ways of relating. And across all four, we're teaching interpersonal effectiveness, communication, and boundaries, the social muscles people need to stay well and to come back from slips without shame. Now, moving on to open versus closed groups. Open groups are the workhorses of higher levels of care, like partial hospitalization and intensive outpatient. People start and end on a rolling basis. Open groups often include members in very different stages of change. Someone in maintenance may be mentoring somebody still in contemplation, showing firsthand that progress is possible. Yes, cohesion can be harder, but the upside is real. Long-standing members model norms, mentor new arrivals, and help set a stable culture. And that mentorship can be profoundly motivating for both sides. Practically, open groups lets you individualize length of stay based on goals rather than the calendar, more client-centered than forcing everybody into the same timetable. Closed groups keep a fixed membership and usually run on a focused theme. So that might be reentry after incarceration, parenting and recovery, or trauma skills. And the predictability helps cohesion, depth, and progressive skill building session to session. So you might be asking, how do I decide which to use? If your program must absorb frequent admissions, open groups make operations and access possible for clients. If your aim is more targeted at skill or identity work like reentry, women in recovery, MAT skills, closed groups can protect safety and depth. I also want to talk a bit about self-help groups. So recovery happens in community long after formal treatment, and that's why we introduce clients to mutual aid groups early and often. These groups include things like 12-step, like AA or NA. There's Smart Recovery, Recovery Dharma, Celebrate Recovery, Moderation Management, Women for Sobriety, Life Ring, and so many more. These communities extend belonging, accountability, and practice space between sessions after discharge. There's robust literature linking self-help participation with better post-treatment outcomes and stronger sober networks. Even on-site meetings can support continuity and outcomes in outpatient settings. And remember, choice matters. For clients wary of spiritual framing, Smart Recovery offers a CBT and social learning path focused on motivation, coping with urges, emotional regulation, and life balance. This can be a really useful alternative to AA or 12-step that still delivers pure connection. Groups like Smart Recovery are especially helpful for clients in contemplation or preparation because they focus on practical skills that support small steps forward. In contrast, 12-step programs often resonate most with people that are in action or maintenance. So why bring this into the lecture now? Because introducing mutual aid isn't an aftercare checkbox. It's part of how we build connection density during treatment. And the fourth thing that I want to talk about here is telehealth and hybrid groups. So group work has shifted in recent years with the rise of telehealth. A virtual room doesn't feel the same as sitting shoulder to shoulder, but many of the same principles apply: safety, structure, confidentiality, and presence. Telehealth groups require extra attention to basics like privacy. Clients should join from a space where they cannot be overheard, and minimizing distractions and setting norms about dress, timing, and crosstalk. Some clients actually feel safer opening up online. They may be more willing to share from the comfort of their own home than a clinic. Others struggle with focus, screen fatigue, or technology barriers. A skilled facilitator will name these dynamics openly, check in with members, and co-create group agreements that level the playing field. We're also seeing more hybrid groups where some clients attend in person, where you might call them the roomies, and some might join virtually. I like to call them the Zoomies. This dynamic can be really tricky if not handled intentionally. The two groups can split and ignore each other. To bridge the gap, facilitators can rotate attention equally between cameras and the physical room, assign roomie-zoomie buddies so that online and in-person members have direct connection, use check-ins that alternate between virtual and in-person voices, making sure each space hears the other, and incorporate activities where both groups can contribute. You can use shared Google Docs, collective lists, breakout groups that pair Zoomies with roomies. And the goal is to create one cohesive group culture, even if people are physically separated. Done well, hybrid groups can expand access while still honoring the therapeutic power of connection. When we talk about group development, you'll notice that different theorists use different language. Gerald Corey describes 4 stages: orientation, transition, working, and termination. Just a hint, you're going to want to remember this for your NCE exam. Now, Bruce Tuckman adds a little bit more nuance with 5 stages instead of 4. And I like because they rhyme: forming, storming, norming, performing, and adjourning. Both models are really useful and both remind us of an essential truth. Groups are living systems. They don't stay still. They shift, they move, they develop, just like individuals inside of them. So starting with forming. So this is going to be Tuckman's forming or Corey's orientation phase. At the very beginning, members are finding their place. They're figuring out, what is this group about? Who are these people? Do I even belong here? Can I trust anyone here, including you, the counselor? So you might hear clients saying things like, how long do I have to be here? Is this going to be like AA? Are you in recovery too? What's happening in the room, you're going to notice members are cautious, polite, maybe testing boundaries. They're going to look to the leader for structure and safety. Your role as the counselor is to set the tone, introduce group norms, talk about confidentiality, respect, and attendance, model openness without oversharing, normalize that it's okay to feel unsure, and begin to shape the culture. This is your group. I'll guide us, but what we do together will come from you. And the next group stage of development, Corey calls it transition, Tuckman calls it storming. This is where things get real. Conflict arises, resistance shows up, people may challenge each other or even you. In addiction groups, this stage can be loud, messy, and full of ambivalence. From a stages of change perspective, storming is often fueled by pre-contemplation and contemplation. Clients who aren't yet ready to give up the positives that they associate with use. Their resistance is part of the work, not an obstacle to it. So in the group, you might hear things like, this was a waste of time. She's always talking about relapse. Why should we listen to her? Or you don't get it. I'm not like them. But what's happening in the room is you're going to see old family dynamics reemerging. Sibling rivalries, parent-child projections, scapegoating, it's all playing out within the group members and within you as a therapist. Members are going to test boundaries, show up late, crosstalk, have side conversations, and ambivalence surfaces as sarcasm, withdrawal, or direct confrontation. From a stages of change perspective, this is often where pre-contemplation and contemplation voices push the hardest. Clients may defend their use, minimize problems, or project frustration onto their counselor or peers. And your role as a counselor is to reframe resistance as ambivalence. Discord isn't failure, it's information. Ambivalence signals movement, not stagnation. Reflect what you hear without escalating. It sounds like you're not sure this group can help you. Thank you for saying that out loud. Who else has felt this way? Invite storming as legitimate. Conflict shows members are investing enough to risk being real. And remember to treat the group as the client. Instead of chasing each individual, hold up a mirror to the group as a whole. I noticed that we're splitting into sides here. What do you think that's about? And most importantly, hold safety. This is how we build enough connection for anything else to happen. So for a second, just think about the forces that your clients face: criminalization, racism, poverty, family pressure, health inequities, trauma. When somebody has learned that authority equals danger, our first task is to be predictably safe. And that means consistency, transparency, and showing members that their pushback will not break the group or drive you away. When you can hold storming this way, the group becomes a place where clients not only face their ambivalence, but also practice new ways of handling conflict, authority, and vulnerability. Skills that they'll need long after treatment ends. And on to the next phase. This would be Corey's working phase or Tuckman's norming phase. And this happens once the group survives storming, norms will emerge. Members begin to trust each other, to listen to each other, and to collaborate. The group feels a lot safer and more predictable. What you might hear from clients in a norming phase or a working phase is, we don't interrupt each other here. Or, remember last week you said something that really helped me. You might even hear them saying, I used what we talked about and it actually worked. So what you'll notice happening in the room is cohesion's building, members are enforcing norms themselves, feedback becomes more honest but is still caring, and the group identity strengthens. Clients are going to start to see this as their space. Your role as a counselor here is to step back a bit, to let members hold each other accountable, and to highlight therapeutic factors like hope, universality, altruism. We're going to continue to keep the focus on the group as the client. What's working for us right now as a group that helps us move forward? The next phase we're going to call performing. So this is Tuckman's performing or Corey's deep working. And at this stage, the group is clicking. Members are vulnerable, accountable, and engaged in real change. They'll test new behaviors in the group and then carry them out into their lives and then come back and tell you about it. What you're going to hear from them is things like, I realized I've been lying to myself about my drinking. Thanks for calling me out on that. Or, can we practice how I'm going to tell my boss that I need time off for meetings? They might even say things like, this group is the first place that I felt safe in years. What you'll notice happening is high trust and high challenge. Members practicing skills together, role plays, feedback, problem solving, and relapse prevention planning feels alive and relevant. Your role as a counselor here is to guide without dominating, to offer structure but allow the group to take risks, experiment, and support each other, and to bring the focus back to the group as a living system. What are we learning together about how we change? And this final stage is Corey's termination stage and Tuckman's adjourning stage. Endings are emotional in addiction groups. They're emotional in any group. Termination can feel like loss, and loss is a major relapse trigger. What you might hear in this phase is, I don't want to leave. What if I relapse? Or I don't think I'm ready yet. Or this group saved my life. I'm scared of what's next. I'm scared of what to do without the group. What's happening in the room is fear of losing connection. Relapse risk increases as the safety net loosens, and members may regress or pick fights as a way of distancing before leaving. You might even see people self-sabotage and relapse on purpose so that they don't leave the group. Your role as the counselor is to name the ending openly. We've been working towards this moment. How do we want to say goodbye? You can create your own system of celebrations as a way to celebrate a person's ending in the group. There might be pizza parties, you might do a coin out ceremony, whatever it is that makes sense for you in the group, but collaborative planning together really makes this work really nicely. I just want to touch on a note here on beginnings, middles, and endings. Different clients will struggle with different parts of this arc, and it's worth slowing down to notice how much weight each one carries. Beginnings can feel overwhelming. Walking into a group for the first time means facing uncertainty, new relationships, and the vulnerability of being seen. For some clients, this recalls the anxiety of first days, new schools, new jobs, or even early family experiences of not knowing whether they belonged. In a group beginning, you may see hesitancy, silence, or defensiveness. Clients might test you with questions like, are you in recovery too? Or mask discomfort with humor. In Gestalt terms, the beginning is about contact, deciding if it feels safe enough to show up authentically. Our task is to make the invitation clear, to normalize the anxiety of starting, and to model that it's okay to ease into connection at your own pace. And then middles are where the work gets messy. This is the storming stage, where resistance, conflict, or fear of intimacy comes to the surface. Clients may clash with each other, withdraw, or project family dynamics onto the group. Some discover that staying present with frustration or disagreement is harder than they expected. In Gestalt work, the middle is where unfinished business often shows up. Those old relational patterns that repeat themselves in the here and now. A client who always retreats when challenged might suddenly go quiet for weeks. Another who fears abandonment may monopolize airtime, pulling attention back to themselves. Rather than seeing these as problems to be solved, we can hold them as material to be explored. What's it like to sit with this tension instead of moving away from it? The middle is where endurance and tolerance of discomfort grow and where intimacy becomes possible. And endings are equally as important and often just as difficult. Closure stirs up loss, abandonment, and the ache of unfinished relationships. A client may relapse or disengage right at the point of graduation, not because they haven't learned anything, but because endings reopen old wounds. Others may cling, insisting that they aren't ready to leave, even when their progress shows otherwise. In Gestalt thinking, endings are moments of assimilation and integration, taking what's been learned and carrying it forward. But they're also moments of letting go, and that can be deeply uncomfortable. As group leaders, we hold endings gently and transparently, honoring both the grief and the pride that come with moving on. And that's why we treat beginnings, middles, and endings with care. Each is both a clinical moment and a practice run for life outside the group. For some, learning to enter fully is the growth edge. For others, it's staying through the turbulence of the middle. And for many, the hardest and most healing work is learning how to say goodbye without relapse or retreat. I want to talk a bit about metrics for success in groups. When we talk about evaluating group therapy, the temptation is to measure success in the simplest way possible: attendance. Did the client show up or not? While attendance is certainly important and can be a marker of success, it's only a starting point. Just being in the room doesn't mean somebody's engaged, connected, or practicing recovery. A fuller picture of engagement includes parameters like participation, disclosure, giving and receiving peer feedback, and role taking within the group. Participation might look like a client sharing their weekly struggles, but disclosure is going deeper, being willing to show vulnerability. Feedback is when clients not only speak, but also listen, offering reflections or challenges to one another. And role taking is when clients begin to step into leadership, welcoming new members, reinforcing norms, or modeling coping strategies. So, how do we track something as complex as group dynamics? One helpful tool is the sociogram. The sociogram is a visual map of who's talking to whom in a group. Imagine a classroom where a teacher does 90% of the talking. On a sociogram, it looks like a starburst. Every line goes from the teacher to the students and back again. Now compare that to a healthy process group. Ideally, in that group, everybody talks to everybody else and the lines crisscross in all directions. The counselor still has a presence, but instead of being the hub of the wheel, they're just a part of the web where all members are connected to one another. Tracking this visually can help us see whether the group is becoming a community or if it's still orbiting around the facilitator. Success also looks like movements across stages of change. For example, a client in pre-contemplation who begins expressing ambivalence, that shift is just as much of a success as somebody in maintenance demonstrating relapse prevention skills. From a motivational interviewing perspective, success isn't about a dramatic change all at once. It's about planting seeds, moments where clients test out a new perspective or voice even a small maybe. And it's also about practicing well, rehearsing skills, experimenting with new behaviors, and building persistence even when ambivalence remains. These are markers of progress that might not show up on a checklist, but they matter deeply. And another way to think about metrics is relational outcomes. We know from Yalom's therapeutic factors that some of the most healing elements in group aren't skills or information, but experiences of hope, universality, and connection. Hope is sparked when a member sees someone a few steps ahead in recovery and thinks, if they can do it, maybe I can too. Universality is the moment when the client realizes they're not alone in their shame, their relapse, or their grief. Social connectedness is the gradual weaving of relationships that hold somebody up when treatment ends. So when we ask, is this group working? The answer goes far beyond counting bodies and chairs. It's about the depth of engagement, the quality of relationships, and whether the group is practicing recovery together. I want you to pause here and just take a moment to think about how you might define success in a group that you're leading. What metric feels meaningful to you? Is it something you can measure, like attendance, participation, or sociograms of member to member interactions? Or is it something more relational, like noticing a rise in hope, pure accountability, autonomy, or the willingness to be vulnerable? How would you track or document that growth over time? And I just talked a bit about Yalom's therapeutic factors, and I want to do a little bit of a deep dive into that too. So, Irvin Yalom described 11 therapeutic factors that explain why groups can be so effective. These aren't abstract theories, they are the lived moments that make group counseling transformative. So, I want to walk through each of the 11 and just think about how they show up uniquely in addiction treatment. The first one being installation of hope. Hope is contagious. When clients see peers making progress, staying sober another week, reconnecting with family, getting a job, they begin to believe that change is possible for themselves. This is especially meaningful for clients in the contemplation stage who may not yet believe that recovery is within reach. An example here would be a new group member saying, I don't think I could ever stay clean. And a peer responds, well, I used to feel the same way, but I'm 60 days in now and it's getting a lot easier. The second factor is universality. Clients often arrive convinced that their struggles are unique. In recovery, this shows up as a term called chronic uniqueness. It's that belief that I'm not like them, so treatment won't work for me. Universality dismantles shame by showing that others have faced the same cravings, guilt, or relapses. It also helps pre-contemplative members begin to see that change talk applies to them too. An example here would be a client sharing, I drank after my mom yelled at me, and another group member replying, I've done that too. Stress at home is one of my biggest triggers. The third factor is imparting information. Groups provide education and skills about cravings, relapse prevention, or coping strategies, but members also teach one another. For clients in preparation or action stages, this is often the nudge that turns ideas into practice. An example here would be a client explaining how they used a grounding technique to manage cravings. The facilitator reinforces it, and others then try it for themselves. The fourth factor is altruism. This is the idea that helping others in the group boosts self-worth and shifts the focus from shame to contribution. Even clients early in change can feel empowered by offering encouragement, while those further along can model persistence. An example here would be a client who relapsed last week, encouraging a newcomer not to give up. That act of encouragement helps both people feel stronger. The fifth factor is corrective recapitulation of the family group. So groups often echo family dynamics. Roles like the caretaker, the rebel, the quiet one. This can be uncomfortable, but it's also a chance to heal. For many, this is where ambivalence in the contemplation stage gets activated. They recognize old patterns, but aren't sure how to step out of them. An example here would be a client who's always felt dismissed by their parents, choosing to share in the group, and the group listens with care. That moment provides a corrective emotional experience for that group member. The sixth factor that Yalom identified was development of socializing techniques. Many clients enter recovery with strained relationships, poor boundaries, or limited social skills. Groups provide real time experience. For those in the action stage of change, this practice is essential. For those in maintenance, it's reinforcement. An example here would be a client learning how to say, I felt hurt when you interrupted me, instead of lashing out or shutting down. The seventh factor is imitative behavior. Clients are often going to model themselves after a peer or the counselor. They try out new ways of speaking, listening, or regulating emotions by copying what they see. For people in contemplation, this might be their first trial step towards action. An example here would be a client beginning to reflect on another story, mirroring the counselor's use of active listening. If you've ever seen that in group, it's really magical when it happens. The eighth factor is interpersonal learning. Groups are laboratories for relationships. Members get feedback that they might not hear elsewhere and can experiment with new ways of connecting. These experiments often mark the shift from preparation to action. An example for interpersonal learning would be a client who tends to dominate conversations, hears from peers, when you talk over us, it makes it hard to share. And then the client uses some feedback to create change in how they engage in the group. The ninth factor is group cohesiveness. This is the sense of belonging, feeling part of something larger. Cohesion is especially powerful in addiction work where isolation often drives substance use. It also provides an anchor for clients moving from action to maintenance, helping them stay consistent. An example here would be members rallying around somebody who admits a relapse. We're glad you came back. Let's talk about what happened. The 10th factor is expressing emotions openly can be relieving and healing. Crying, venting anger, or sharing grief. In addictions groups, this must be balanced so it doesn't overwhelm the process or other group members, but catharsis often shows up when contemplation clients finally voice what they've been holding back. An example here would look like a client breaking down while describing the loss of custody of their child. The group listens and validates, making space for release without judgment. And the final 11th factor is existential factors. Groups allow clients to confront big picture issues like mortality, freedom, isolation, and meaning. Addiction often raises these questions starkly. Clients in maintenance may find existential reflection especially important as they build a life beyond stopping use. An example here might be a group member saying, I don't know who I am without drinking. The group holds that tension and explores meaning in recovery. Being a group leader in addiction counseling is a little like being the conductor of an orchestra. You're not playing every instrument. In fact, if you tried to play them all, the music would fall apart. Your task is to bring the pieces together, to help each voice find its place, to notice when one section is overpowering the others, and to keep the whole group moving in rhythm. Your tasks include assessing group needs. What's really showing up in the room right now? And building culture. Early on, this means establishing and reinforcing norms like confidentiality, respect, showing up on time, allowing everyone a chance to speak. Over time, it's less about telling and more about inviting the group to hold itself accountable. What agreements do we need to revisit today to feel safe here? Your skills are the subtle tools that keep the group in tune. Flexibility and adaptability are essential. No matter how much you prepare, the group has a way of presenting something new. Reading the meta story means stepping back and noticing the bigger picture. Maybe the content is about relapse prevention, but the process is about members competing for approval. Linking is when you connect one person's story to another. I hear something in what Joe just said that might resonate with you, Maria. Blocking is when you interrupt behaviors that harm the group. Side conversations, repeated interruptions, sarcasm that silences others. And healthy confrontation means addressing these issues directly but with empathy. Like saying, when you cut him off, it seemed to shut him down. Can we pause and hear him out? Summarizing pulls the threads together so that the group doesn't get lost in tangent. Another important skill is knowing when to magnify some voices and minimize others. In any group, some members will naturally dominate while others hang back. If we let that dynamic run unchecked, the group's music gets distorted. Sometimes you need to amplify the quieter voices. Hey, I noticed you've been quiet today, Sam. Would you like to share what's on your mind? so that they feel heard and valued. Other times, you might need to gently turn down the volume on the dominant members. Thanks for sharing, Anna. Let's pause and give someone else a chance to respond. This balancing act keeps the group democratic, where everybody has a chance to contribute to the collective work. And special considerations are unique to addiction work. Culture matters. Groups must feel trauma-informed, safe, and trustworthy. Confidentiality must be emphasized constantly, not just as a rule, but as living practice. What's said here stays here. Boundaries protect both clients and counselors, being clear about dual relationships, not letting familiarity blur professional lines, and trust is fragile. Once broken, it can take the whole group down. Practicalities also shape the group. Size matters. 12 or fewer allows everybody to participate without being lost in the crowd. Duration and frequency depend on level of care. Partial hospitalization groups may meet for 4 or more hours a day, while outpatient groups may be just an hour or two each week. Preparation is key. You need a plan, but you can't cling to it. The art of group leadership is showing up prepared and willing to toss out your agenda when the group's needs call for something different. So back to our metaphor. As the conductor, your job isn't to force every instrument to play the same note. It's to help them find harmony. Sometimes that means quieting the brass so that the strings can be heard. Sometimes it means letting percussion take over for a bit of energy. And sometimes it's about holding silence long enough for the music to breathe. And in the same way, leading a group means balancing structure with responsiveness, magnifying some voices while minimizing others, and trusting that with guidance, the group can make music together that no individual could play alone. And when we think about group therapy and addiction treatment, it helps to start with the ideal world. In a perfect world, intensive outpatient or IOP groups would be filled with clients who are at the preparation and action stages of change. These are people motivated to do the work, actively exploring coping skills, managing cravings, and experimenting with new behaviors. They might have higher relapse potential, co-occurring symptoms that need structured support, or unstable environments that make extra group contact essential. Outpatient or OP groups, by contrast, would look more like action and maintenance. These clients would be relatively stable, often practicing relapse prevention skills, strengthening recovery networks, and fine-tuning boundaries and lifestyle choices. They'd come in with greater consistency, fewer acute crises, and a more solid base of external supports. But that's the textbook version. In reality, it rarely looks that clean. We often see IOP clients who are still in pre-contemplation or contemplation. They may be attending only because a probation officer, family member, or employer pushed them into care. Some may even be actively using, treating IOP as the least restrictive level of care they could get away with instead of going to inpatient. The severity of their substance use may be high, but the readiness is not. And even in OP, sometimes we see clients who are in active use, not yet taking consistent action steps. Maybe they're working full-time, raising 2 kids, and building a life worth living. They just can't swing 9 hours of IOP group per week, no matter how clinically appropriate it might be. ASAM and the stages of change give us helpful guidelines, but the truth is that life doesn't always fit neatly into the levels of care. And this is where real work begins. Every group you lead will contain a mix. Different stages of change, different severities, different worldviews, cultures, recovery goals, and drugs of choice. Group, in many ways, ends up looking like the real world itself, a space full of diverse needs and competing realities. That diversity can feel overwhelming if we cling too tightly on what the group should look like. But if we accept the group as it is, we can find ways to help clients feel connected to each other, to themselves, and to their own recovery process. One practical example, Dimension 4, Readiness to Change in ASAM. So in IOP, that might mean using psychoeducation to help contemplative clients recognize ambivalence as a normal stage, while simultaneously supporting action stage clients in skill building. Both can be in the same room. Your job is to tailor interventions so each feels seen. And this is where the paradoxical nature of change comes in. If we show up with rigid expectations, deciding ahead of time what every client should be doing at this stage or in this group, we risk losing them. But if we show up with presence, preferences, and flexibility, we create space for clients to surprise us. The paradox is that the less we push for change, the more likely clients are to risk trying it. So yes, group is fun, but it isn't easy, and it definitely won't be easy if you keep focusing on what it should look like instead of what it actually is. The real art of group counseling is embracing the messiness, trusting the process, and walking alongside clients as they move, sometimes slowly, sometimes unevenly, toward their own version of recovery. Echoing on that and talking about mixed motivation groups and harm reduction, one of the most important truths about group counseling and addiction treatment is that not everybody walks into the room wanting the same thing. Some clients arrive clear that abstinence is their only path. Others want to cut back or use more safely. Still, others are there because they're mandated or because family pressure finally outweighed their resistance. In motivational interviewing terms, this is ambivalence, and it's not a problem to be solved. It's the ground that we work on. Welcoming ambivalence means treating it as a normal part of recovery. When a client says, "I'm not sure I'm ready to stop," instead of correcting them, we lean in with curiosity. What do you enjoy about using? What are some things you don't enjoy? That's motivational interviewing spirit, exploring both sides without judgment, knowing that ambivalence is often the doorway to change. In groups, this gets complicated because members hold different goals and worldviews. Some may feel strongly that abstinence is the only real recovery, while others are experimenting with moderation or medication-assisted treatment. Our task is to balance abstinence and harm reduction in groups. This means setting the tone early. This is a space where all recovery goals are respected. We may not choose the same path, but we're here to learn from each other and support each other's progress. This also means supporting MAT conversations. When somebody shares that they're on buprenorphine or methadone, the group leader's response matters. Rather than letting stigma take hold, we can normalize and affirm. Medication is one of the ways that people stay alive and engaged in recovery. Let's make space for what that means for you. In a harm reduction frame, we also value incremental progress. A client who moves from daily use to 3 times a week or who starts carrying naloxone is taking real steps towards health. In motivational interviewing language, these are change talks, small shifts in behavior and perspective that we want to catch, reflect, and reinforce. We also reframe lapses as learning opportunities rather than failures. Instead of, "I blew it, I'm back at square one," the group can help reframe, "What did this slip teach you about your triggers? What will you try differently next time?" Ultimately, harm reduction in groups is about creating inclusive culture. It's easy for group members to compare and compete, but we can redirect towards collaboration. In Miller and Rolnick's words, the counselor stance is one of partnership, evocation, and compassion. We don't force readiness. We draw out what's already there, planting seeds and practicing well. So when you step into a mixed motivation group, remember your job isn't to get everybody to the same destination at the same speed. It's to hold space where people can explore, compare notes, unlock new parts of their map, and move forward in ways that they're willing and able. And that's the paradox of this work. The more we let go of control, the more room clients have to grow. And I know I've said this 100 times already in this training, but groups work best when people feel safe, respected, and engaged. But there are some non-negotiables. Times when a client's behavior disrupts the group or threatens safety so significantly that we have to consider discharge or referral to a higher level of care. Common examples include repeated inactivity in care, clients who chronically skip groups or sit silently without participating despite support and redirection. Another is presenting under the influence in ways that disrupt the group. If somebody is impaired and unable to stay safe or respect the space, we just can't ignore it. Safety for the whole group has to come first. So here's some simple language that you can use when somebody shows up impaired. "I can see that you're not in the place to fully participate safely today. For your safety and for the group's safety, I'm going to ask you to step out. We'll follow up individually to figure out what support you need right now." Or you could try, "I'm so glad that you came because showing up matters, but it's not safe to continue group when you're under the influence. Let's pause here and make a plan for next steps." Most agencies have rules, sometimes 3 strikes relapse policy, but harm reduction challenges us to think more flexibly. A relapse doesn't automatically mean failure or that somebody needs to be punished. Sometimes relapse is an opportunity for learning, and the group can hold that person with compassion. But if relapse turns into repeated disruption or creates risk for others, then we might need to step up into a higher level of care or put boundaries around their participation. This is where clinical judgment matters most. It's not always black and white. One way to navigate this is to bring the group into the process. Rule setting can be collaborative, and at the forming or norming stage, it's really helpful to say, "Hey, let's talk about what respect looks like in this group. What do we expect of ourselves and of each other?" This helps clients take ownership, and it also creates buy-in when those rules need reinforced later. But here's the important part. Rules need to be clear and specific. Saying something like "respect everyone" isn't enough. Respect might mean putting your phone away during group or not swearing at someone, even if swearing in general is okay. My guideline is this: swearing is fine when it's about expressing yourself honestly. It can even be cathartic. But derogatory language, racial slurs, or words that make somebody feel other than are not okay. Respect is about building connection, not tearing it down. So here's some language that you can use when clarifying what respect can look like in a group. We've all agreed on respect as a ground rule. Let's talk about what it actually looks like in this room. For example, respect is putting our phones away Or maybe it's about language. How do we want to define it together so that we're all on the same page? You can also say something like, swearing can be a way of expressing yourself, and that's fine. But swearing at someone or using language that puts someone down isn't respectful. Respect here means expressing yourself without hurting or demeaning others. Also, notice how rules here are phrased. It's not a list of no's, no running, no yelling, no cursing. That's going to tell people what's not welcome, but it doesn't guide them toward what is. Instead, we can use welcoming and connecting language. Imagine a list of rules like practice active listening, step outside if you need to take a call, speak your truth but don't attack others. This frames rules as shared commitments and not punishments. Remember, group rules aren't fixed forever. As people move through the forming, storming, and norming stages, their expectation of self and others shift. Rules should be revisited and clarified along the way. Talking about rules is also a great way to start a conversation about boundaries. Many clients with substance use disorders and often co-occurring mental health challenges struggle with boundaries. Boundaries are the personal rules and limits that help us define what's okay and what's not okay in relationships. Some clients come in with rigid boundaries, others with porous ones. Group is a perfect place to explore what healthy boundaries look like in practice, both with self and with others. Setting group rules together is one way of practicing this skill in real time. So while discharge and referral are sometimes necessary, they aren't the starting point. They're the last step when safety or engagement simply can't be maintained. And more often, the work is about helping clients clarify expectations, define respect together, and practice boundaries in a supportive, structured space. In the end, group rules aren't about control. They're about creating the kind of environment where people can take risks, be vulnerable, and move towards change. Addiction groups bring unique dynamics that you won't always encounter in other counseling groups. These dynamics can make the work more complicated, but they also provide opportunities for really deep healing if handled with care. So let's walk through some of the most common challenges and how to approach them. Starting with trust and confidentiality. Confidentiality is the foundation of group work. HIPAA protects clients from providers disclosing their information, but it does not stop group members from talking about each other outside of session. And that's why we must set a clear norm. What's said here stays here. Trust also means being thoughtful about admissions. In small communities like Pittsburgh, it's almost inevitable that people will know each other through family, recovery housing, workplaces, or social networks. Ideally, we avoid putting close friends or adversaries in the same group, but the world isn't perfect. When overlaps happen, don't ignore them, address it directly. It sounds like there might be a conflict of interest here. Let's talk about what needs to happen so that everybody can feel safe or whether a different group might be a better fit. Trust takes time to build, but cracks, if left unattended, can erode safety quickly. The second is looking at handling relapse disclosures. Relapse is a reality in recovery, and how a group responds matters. If a member discloses relapse, the counselor sets the tone. A shaming response can drive silence, and a compassionate response can create learning. Language you might use might sound like, "Thanks for being honest about your use. That takes a lot of courage. Let's explore together what happened and what support you need." Or you could even say something like, "Group, how do we want to respond when one of us struggles? What would support look like here?" You want to encourage empathy and not judgment. Relapse isn't about starting over at zero, it's a recycling of the stages of change, often moving someone from maintenance back into contemplation or preparation. And the group can frame relapse as data: what triggered it, what was learned, and what can be done differently next time. The third thing that I want to talk about is dealing with ambivalence, denial, and resistance. Ambivalence and resistance are not barriers, they are expected parts of recovery. Clients may deny having a problem, minimize their use, or argue with the counselor. In group, this can ripple out quickly. Motivational interviewing helps us reframe resistance as information. "I hear you saying that you don't think your use is a problem. What are some things that you enjoy about it? And what are some things that you don't?" We also want peers to learn healthy responses. The goal isn't for the group to gang up, but to model curiosity. Who else has felt unsure about whether they wanted to change? What helped you sort it out? Ambivalence is contemplation. Denial is pre-contemplation. Both are doorways, not walls. By modeling patience and curiosity, the group shows that being stuck is still part of the process. And then there's diversity of member histories. Addiction groups often bring people together whose backgrounds could create tension: drug dealers and clients who've lost loved ones to overdose, people with co-occurring trauma, or members from vastly different cultural or socioeconomic contexts. The counselor's role is to acknowledge differences openly. We all come into this room with different histories and perspectives. That diversity can make us feel uncomfortable, but it can also be a powerful teacher. Let's focus on what we can learn from one another. At times, you'll need to set boundaries around harmful or triggering comments. I need us to stop here. That language could be very painful to some group members. Let's reframe what you're trying to express in a way that feels safe for everyone. And when handled with care, diversity can transform groups into corrective emotional spaces. It's places where clients confront difference without avoidance, learn empathy, and practice tolerance. In some, addiction groups will always surface issues of trust, relapse, ambivalence, and diversity. How we handle them as counselors and how we invite the group to respond determines whether these moments become ruptures or opportunities. With consistency, compassion, and structure, these challenges can foster growth, accountability, and connection, helping clients move through the stages of change together. And before we end, I have one more thing that I want to make sure that we talk about today, and that's counselor self-care in group work. Running addiction groups is one of the most rewarding works that you will ever do, but it can also be some of the hardest. When you sit in a room full of ambivalence, anger, grief, relapse, and hope, week after week, day after day, you're not just facilitating, you're absorbing. And without care, the cost can show up as burnout, boundary problems, or countertransference. And burnout isn't just feeling tired. It's a tide of hopelessness and futility that can swamp even the most dedicated therapists. It often looks like depression, but it's tied directly to our work. Signs include dreading voicemails, secretly celebrating cancellations, or feeling a creeping disconnection from clients. The danger is personal, and it can erode effectiveness and even compromise ethics. So what do? You start with navigating storming and criticism. Groups are going to push back. Clients will criticize your style. Some will test limits or call you out. Pushback is not failure, it's part of the process. And you can use self-talk strategies in the heat of the moment. Tell yourself to take a breath. Don't take it personally. Ask yourself, what else might be going on here? Think of it as practicing what we teach, using reframing and mindfulness on ourselves. Regarding boundaries, we want to practice empathy with authority. Therapists walk a tightrope between being warm and being firm. The boundaries that we set are as much to protect ourselves as our clients. Healthy boundaries aren't walls. They're guidelines that allow mutual respect and safe connection. And that means saying yes to vulnerability and humanity, but no to harmful behaviors, dual relationships, or blurred roles. And then touching on countertransference and supervision. It's inevitable that certain clients will stir up strong reactions. Anger, attraction, guilt, frustration. Freud called countertransference both the therapist's greatest tool and the greatest obstacle. The difference lies in awareness. Use supervision, consultation, and your own therapy to unpack what shows up for you. It's not about never having reactions, it's about not letting them drive the bus. And looking at practical self-care. Prep before group, but hold plans lightly. Decompress after group, walk, journal, debrief, take a lunch break. Use professional associations for connection and renewal, and remember, you can't meet every need. You will make unpopular calls. Not every group member will like you, and that's okay. We can also look at group member styles as a mirror. Self-care also means learning to ride the waves of group dynamics without drowning. Think about the types of people that you'll encounter. The leapers, the creepers, the weepers, and the sleepers. Leapers jump in early and often. Great energy, but sometimes they overshadow others. The creepers are quiet, observant, slow to engage, and they may need direct invites or eye contact. The weepers are the criers. They're deeply moved, often holding emotional weight for the group. And then there's the sleepers, literally or figuratively checked out, scrolling on their phones, zoning out, sometimes using actively in a group. Each style offers different responses, but notice your own reactions. Do you get frustrated with sleepers or overly rely on leapers to avoid the tears of weepers? Self-awareness here is crucial. These dynamics mirror family roles, trauma triggers, and also your own group identity in staff meetings, classrooms, or even family dinners. So here's the takeaway. Self-care and group work is not just bubble baths and vacations. It's the ongoing discipline of boundaries, supervision, reflection, and compassion for your clients and for yourself. Groups will test you, but if you can stay grounded, flexible, and human, those very challenges become your best teachers. Group therapy in addiction counseling is both an art and a science. The science gives us frameworks, ASAM criteria, motivational interviewing strategies, Yalom's therapeutic factors, stages of group development, stages of change, and the art is how we bring them into life, moment by moment, client by client, group by group. Success in groups isn't measured just by attendance. A full roster means little if members are disengaged, silent, or disconnected. Real success looks like engagement, culture, and responsiveness. It's clients leaning in, giving feedback, taking risks. It's the group learning to hold each other accountable and to carry hope when somebody can't hold it for themselves. Groups are microcosms of life. They surface ambivalence, conflict, relapse, and grief, but they also create space for connection, catharsis, and growth. Within the group, clients practice the very skills that they'll need outside: boundaries, honesty, empathy, and persistence. And that's where the counselor's role comes in. We're not here to force change or to control outcomes. Our role is to welcome resistance as a part of the process, to set structure and safety, to support persistence even when progress feels small, and to build a culture where recovery, in whatever form that takes, is possible. And if you take nothing else from this lecture, let it be this: groups are living systems. They will surprise you, frustrate you, challenge you, and teach you. But if you show up with structure, flexibility, and compassion, group therapy can become one of the most powerful healing tools we have in addiction treatment.